Hello, friends.
Hi, good
Warm
evening, sir.
welcome. Good evening to WDA. Good evening, Dr. Anand. So today again we are with our next lecture on Endo Masterclass with very eminent personality, Dr. Professor Raghu Narayan, and he will be talking on post and core in endodontics. I'll invite Dr. Anand to give his short resume, and we'll invite Dr. Raghu onto the stage. Yes, Dr. Anand, please.
Hi, Professor Raghu. How are you?
Welcome, sir.
I'm good, Anand. How are you all doing?
All good. How's Bangalore doing, sir?
We are competing with Mumbai. So very soon we are going to.
I hope you don't win this race.
We don't want to,
Nobody
but
wants to win this race.
true, very true. Yeah,
Mumbai and Delhi are fighting for the first spot. So let's see who wins.
yeah, we are right behind you people. Not
Great.
happy about
So
it
it is
though.
obviously. So it is a great honor to have Professor Dr. Raghu Narayan sir with us. He is a professor and a microendodontist. He graduated from M.R. Ambedkar Dental College and Hospital and did his master in endodontics from Rajiv Gandhi University of Health Sciences, Bangalore. He has done his advanced endodontic course from the University of Florida, USA, microendodontics from the University of Buffalo, and master clinical training at the University of California, Los Angeles. You have been to everywhere in US, sir, I guess. He is an active member of national and international endodontic societies and conducted lectures and deliberations about modern endodontics at national and international conferences and forums. He has published multiple articles and columns regarding modern dental treatments. He's the founder director of Academy of Advanced Endodontics Bangalore and has trained more than 3,000 dentists on modern endodontics from across the globe. He's also the program director of Advanced Endodontic Principles Program at the University of Buffalo, USA, the academic director for modern endodontics at Dental Academy of Clinical Excellence, DACE, USA. He's a research advisor and key opinion leader for various national and international manufacturers. And he runs his beautiful practice in Bangalore, where he is conducting courses and he is treating patients for microendodontics, retreatments, aesthetic dentistry, and implants. It's an honor to have you with us, sir. The
It's
stage
my
is all
pleasure.
yours.
Good evening to you
Yes,
all.
sir.
Thank you, Dr. Saurabh, Dr. Anand, for a wonderful introduction.
Thank you, sir.
I'm honored and it's my pleasure to be on this platform. You people are really doing an amazing job, especially during this crisis where all are stuck and we are trying to take the best out of the crisis. We're sitting at home and we are still able to gain the knowledge. And today I'm glad that I got this opportunity to share a little knowledge, a little experience, whatever I have gained over the last 2 decades. Having said that, post and core is such a topic I would like to give my understanding towards all the listeners. Think like this. When you think of a conservative dentistry, there is an entry level treatment. We call it as probably enameloplasty. That is where the entry level treatment happens. And the indirect pulp capping would be the last. Anything beyond that, maybe a direct pulp capping comes to the realm of endodontics. Likewise, where the endo ends at the level of post and core. If the post and core is not really possible for any tools, then probably it would either go for an implant or an extraction or a bridge, whatever it is. The way I understand is the last resort for this tooth to survive in the mouth as a functional entity is our post and core. But before we get into the post and core as such, we need to understand what is not post and core. This I'm little not so very happy to share some of the images or some of the pictures with you all. What what is really happening with many practitioners. We cannot call this as a post and core, though there is a post, there is a core, and everything, but it's not in the right place. Obviously, even this can't be the post and core where you drill however you want because patient is under anesthesia and you have a drill. No, this can't be the post and core. How about this? Maybe someone has maintained a parallelism but not along the route. Obviously, we have an issue with such things. And like this, there's so many things. We are literally, instead of giving a last chance to the tooth, we are just culling the option of whatever the tooth ever had. How can we call this as a post and core? When we damage the root, when we damage the tooth, and when we take away the life of the tooth forever. So there are many things that is happening, and this topic becomes very, very important and critical from the today's perspective, because if not post and core, we are thinking of any other alternative therapy which is extensive as well as an expensive therapy from the today's dentistry perspective. So, what is post and core from the clinical perspective? Today, I'm keeping the whole of my understanding and my deliberation and everything towards the clinical aspect of like how do we do it, what are the little compromises we do, and what are the little deviations or we little changes we adapt to gain the maximum benefit of the available route. So clinically, the post and core is, by definition, I can say it's a rigid restorative material placed in an endodontically treated tooth. Now, when I say endodontically treated tooth, it's not a symptomatic tooth. It has to be a perfectly sealed, perfectly healed, asymptomatic, endodontically treated tooth, which has lost certain amount of tooth structure, that is coronal structure, can be considered for this post and core therapy. Now, this material has to be rigid because the specific words I'm trying to use is probably it help you in a MCQs towards the end of the session. Restorative material, rigid. This can be flexible, this can be semi-flexible. It has to match the flexibility and other physical properties of the dentin and enamel. The primary objective we have to understand. This is a very simple case where there was a fracture at cervical level. There is hardly any dentin around that. There was a crack in this tooth. Unfortunately, I could not share that one. Some of this, like where we had to do a little crown lengthening and then go for a fiber pose. Then I can give a life to this tooth. Otherwise, imagine the condition. Either it is an extensive therapy like a implants or probably a bridge and things like that. I don't think any patient would be opting for at that level. There is another condition where patient had a fracture in such a way that if you could notice, this tooth was a bit labially placed. This is some of the I'm just trying to give you a basic idea about like how the post and core can save a tooth. Now, individually, we can fix all the teeth just by restoring or giving a little anchorage to the existing tooth structure, which may not be otherwise able to take the load. Things like this, where a wrongly done post, which is instead of giving support to the core, probably it was taking a support from the core and was staying there. Again, there's a little bit of crown lengthening procedure, and then build up a core, and then beautifully we can restore it. We can put a double post. End of this thing session, I'll be coming back to these things, like to show what how this can be achieved. So by default, when I say post and core, it is a restoration done on a compromised coronal structure which has been undergone for an endodontic therapy. So end of the day, we will have a post, a core, and a coronal restoration. Here, the most important thing for us would be a stable or asymptomatic endodontically treated root, which is strong enough to take these loads. Let's come back to our final configuration. Once we are done with the endodontic, once we are done with the post and core therapy, what is left with us, or what is the final configuration, is this. We have a very strong root, which is anchorage to the core by means of a post. We gain an additional additional retention from here, and then probably a crown is attached, or maybe the core itself maybe sometimes takes the role of your crown, depending on which type of a crown you're planning it. So this is what we are trying to understand in today's lecture. If I'm going a little fast or something, Anand and Saurabh, you need to tell me, give me a hint. So if I have to take a cross section of the post and core tooth, which is with the fiber post and a core built up with a composite, probably this is how it would look on the X-ray. Probably this is how we can see that one. a post and a core built up, which is perfectly bringing a monoblock effect, which can compensate the last part of the tooth. Some time back, we used to heavily depend on this rigid metal post. Now we have moved away from that aspect. We don't like anything which is stronger, rigid than the dentin itself, because end of the day, if at all, if I have to compromise on the strength of the post or strength of the root, I would compromise on the strength of the post, because like if as long as the root is there, I can think of an alternative therapy. But if the root is fractured and the post is intact, it doesn't really help me in any which ways. So from that aspect, a metal post is not my personal favorite, and even the studies support a lot. And let's move on. We need to understand, why do we give a post? By default, if you're under the impression that by giving a post we are going to strengthen, hold that thought. That is I'm going to clarify on that specifically. What is the purpose? What is that we are trying to achieve with the post and core? This is what it is. If there is no post, there is not a sufficient amount of a tooth structure to hold the core, which is in turn going to help me hold the crown. So hence, the post and core is primarily, it's a retentive form. It is supporting the core part of the tooth, and which is going to help to achieve a clinical crown as a functional, aesthetically fulfilling, and as a function, as a masticatory and masticatory or functionally active tooth. This is what it is. So primarily, it's an anchorage. It is the little retention what we are going to get from this post, and the other benefits of this post would be the remaining tooth structure by default gets strengthened. Strengthened as in like not the whole overall strength of the tooth. It is like if there is no post, obviously the remaining part of the tooth might get compromised. That little bit of tooth structure what is available above the supragingival level, even that might fracture. Of course, by doing a post and core, we are protecting the remaining tooth structure. Marginal integrity is something where once the tooth is intact, once we achieve the monoblock effect, with whatever the latest post we have, probably the marginal integrity from the perspective of your soft tissue, from the functional, from the finish lines, from the bonding, from all this perspective, we get a very good marginal integrity to keep the tooth intact. Now, when I say the purpose, so ultimately we are talking about the core and a crown retention. We are talking about the restoration of a lost tooth structure and to protect the remaining tooth structure. This is what the ultimate thing we are trying to achieve from the post and core. Now, let's see. The ideal requisites, you may be always wondering, those who are like fresh graduates and all those things, why do we need an ideal requisite for any topic? For example, ideal requisite of a restorative material, ideal requisites for an impression material, or ideal requisite for a post. The idea behind this ideal requisite, when we jot it down, the basic idea is like that is our wish list. That is what we are trying to achieve with our invention and with our all the studies and reports and everything. So once we have all the points checked, and if once it is fulfilled, that means that okay, we have achieved that thing. But when it comes to post and core, have we achieved all of it? To the larger extent, yes, but not completely. So ultimately, what we want is a post which gives a maximum protection to the root by distributing the forces, adequate retention to the root with the core, adequate maximum retention to the core as well. Marginal integrity, aesthetics, radiographic visibility, we should be able to retrieve it, and of course, it should be biocompatible, not disturbing the adjacent tissues or adjacent restorative materials as such. So this is what we want, and we have evolved over the centuries, ranging from a small wooden stick supported tooth to most biocompatible, most physically compatible a fiber post, which exactly matches the physical properties of the dentin. So that is where we are as I'm today. So when we say we have this varieties of posts, we need to understand the classification as well. Classification of the posts is like, if that comes as an MDS 100 marks exam, believe me, at least like 30 pages you can write the post and core classification itself. It can be classified as technically as an active passive post, or it can be as simple as post done with the right hand, post done with the left hand. Now, there are numerous classifications: aesthetic post, metallic post, prefabricated post, custom made post. We have a glass post. We have, depending on the composition, depending on the shape, depending on the size, depending on the tooth, depending on the purpose. We have various types of classification available. But we need to understand what is the most sensible classification. Broadly, as a beginner or as a with a less experience with the post and core, this is what would help us predominantly. Custom-made posts are made for the specific tools. Make a post space. I'll share some of the videos towards the end of this session. Custom-made post is like specifically made for the configuration of the existing post space. That may be oval, that may be triangular, that may be ribbon shaped or whatever. That's a custom-made post. Prefabricated posts are, it's like they are stock posts, they are available in the market. You buy the different sizes and things like that. This is an example of a custom post made for this specific tool, cast it, then lute it onto this tooth structure to gain the additional retention. When it comes to, these are all the custom posts available. Basically, it is like take the impression of the post space, or maybe make a direct impression, send it to the lab, and then get the structure done, cement it, and then crown over that, something like that. Nowadays, we have this digital scanners. We can even think of the zirconium post or aesthetic post milled in the lab. That is something we should be concentrating. We should be focusing in the days to come. There is a partial, or we can call it as a semi-custom or a partially prefabricated post, where the drill is provided for the post space, and then you attach a fiber post into that, or a plastic post, and then make a wax pattern, and then send it to the lab, and then the whole thing can be replicated in the aesthetic form. This is something new that is coming up. The prefabricated posts are many, ranging from your carbon post to glass post, ceramic post, and even the zirconium post. Prefabricated zirconium posts are available now. When it comes to metal, which is not my favorite post though, there are all these flexi posts. These were the mainstream of materials what we used to use in the restoration, specifically coming to the post and core. So these are all the available things under prefabricated post. Then we have specifically, I'm putting this class composition slide for you all to understand. We prefer the fiber post for the simple reason that we can bond them. We can achieve easily a monoblock effect. We can bond the luting cement to the dentin, and dentin to the post, and the whole thing will become a one unit. The reason for that is there is a BIS-GMA, there is a fiber glass, and we can easily trace them on the X-rays as well. So this is what is the in thing as in today. Advantage of a fiber post is, as I said, the modulus of elasticity or the physical properties are almost similar to the dentin. That means its flexural strength, its compressive strength, its tensile strength, everything is very, very similar to the dentin. That means that when the dentin flexes, even the post flexes exactly like that. This is very important for us. If a rigid body at the center is flexing and the dentin is not flexing, that is going to create a crack, or that is going to create some kind of a physical deformity, eventually leads to a fatigue and kind of a damage to the root. It can be bonded to the tooth. It is aesthetically appealing, and it is non-corrosive, very, very biocompatible compared to any other types of a metallic post. The greatest benefit, personally, what I see is, if you have done a fiber post, the fracture is always at a cervical level. If not anything, you can still think of saving the root in terms of partial extraction therapy, or probably you can have the root being saved for a while till the patient decides on something. But imagine something like this. Whenever we go for a metallic post, the fracture is always at the terminal part of the post, which is at the apical third. Any such fracture, we'll have to extract the tooth and we have to think of an alternative things. Probably if there's a fracture at this level, maybe I can even think of another post, but not in these conditions where the metal will put up stress on the weaker part of the root and eventually causes the fracture. There used to be one specific disadvantage, which I don't personally believe it as a disadvantage. The fiber posts are more or less radiolucent. There are certain product manufacturers. They add a barium salt and various other radiopaque materials. Nowadays, that's not even a big thing. You can actually, the radiolucent thing itself can be traced to the specific depth to see where exactly the post ends. What are the factors to be considered before we think of a post and core? We need to know what should be the post diameter. We should be know what is the post length. We should be knowing what is the type of cement we can use it and what are the type of the canal or a root we are dealing with. We cannot think of a post for all the roots. We cannot think of all the materials for every given root. So it has you have to have an idea what gives you the maximum benefit in terms of rigidity, in terms of matching the dentin behavior, in terms of aesthetics. You need to have a basic idea how to select this post. So when do we advise the post? That's the big question. It is as in today, we don't have any specific guidelines which clearly demarcates this is for the post, this is not for the post. We do not have that one. It is very, very subjective. It is more or less, it is a clinician's discretion. He would more or less decide depending on the opposing tooth, depending on the age factor, depending on the damage, depending on various other things. There is not a specific aspect or a parameter which can be considered as a clear indication for the post. This is always a debatable thing. I specifically quote this. This is Gordon Christensen, who claims that when there is less than half of the tooth structure is remaining, that is when you need to go for the post. Of course, the studies and surveys and many other things there that we just need to have at least a 2 millimeter of supracoronal tooth structure to have it. Dr. Christensen being Christensen, he's got his recommendations always. He's got his own lab to claim whatever it is. Post is not needed if the tooth structure is around 4 millimeter. That is something we need to keep in mind. That means that when the tooth structure, when he says half of that length is, so more or less he is also coming to the same platform as remaining tooth structure is should be around 2 millimeters in the clinical side. Let's not go away from the evidence. What we know as in today is the post is not going to increase the strength of the root or the tooth. As I said, let's not forget that post is a last resort. If I take a little liberty and if I make a specific claim, I would say if not post, the tooth has to go for an extraction. Hence, the post is comparatively better option than going for an extraction. Think from that perspective. If you don't do the post, it has to go for an extraction, an alternative, a method of replacement of a tooth. Now, here is a compromise, but it's a better compromise. Compared to extraction, you have a better a condition where you can give a life for this tooth for few more years, depending on the condition. So, technically, if somebody is under the impression that, okay, post and core is going to strengthen the root or strengthen the tooth, it is not. The sole purpose of the post is to retain the core. That's it. Nothing more than that. Coming back to the clinical aspect, when patient comes to a clinic and when he's got some pain, when he's got a fractured tooth, when there's a compromised condition from the masticatory or aesthetic, from the functional or phonetic perspective, we need to see how to compensate those missing things. Be it a coronal structure, be it an aesthetic, be it a functional aspects of it. Now, the question is, should we give the crown? Here is a beautiful study published in 2005, which says the first year survival, even without a crown, is 96%, but none of them reached 36, the 5 years thing. There's another study, unfortunately, I don't have it here. I can share it a little later. 10 years, most of this tooth, which is just restored with a bonded restoration, they probably don't see the 10-year anniversary at all. So that is the condition we have most of the time when we have uh, a tooth, especially the posteriors. Without a crown, their survival rate at 10 years is less than 20%. Now, coming back to our topic, how much of minimum truth is required to consider the Poston code? Can I do the Poston code for a root stump? Yes, you can do it, but that root stump needs to have certain amount of truth. The answer is very simple. You need to have minimum of 2 millimeter of a tooth structure all around the tooth. That is like, here it is. You need to have this minimum 2 millimeter of a tooth structure to get that ferrule effect. You need to have that strength. Technically, you need to have your finish line over the tooth and a supracoronal of dentin of at least 2 millimeter. Can we do a post for this condition? Of course, you can do it, but you should know that it is a compromised condition. Can we do a post for this? Definitely not. No, if there is no supracoronal tooth structure of not around 2 millimeter, at least on three walls, it is a compromised treatment, but that can also be a treatment plan. A consented, a compromised prognosis, also a treatment plan. You all should know that. Our clinicians know this very well. I'm going to early morning, you have a patient, the first patient walks in and he says that I need to go to office. I have broken the tooth. And you cannot say that no, you have to either think of a bridge or an implant and all those things. You need to give something there. Patient knows that it is not going to be a permanent treatment. Of course, you want to put the post, you know very well it's not going to be the permanent treatment, maybe for a week, maybe a couple of weeks, and patient is very careful about it. Yes, that is a compromised treatment. Yes, we have done such things, and that is only for a transient period till we arrive at a permanent treatment, something like that. This is what the guideline is. If you have a 2 millimeter, okay, your post is going to be stronger and you have a better prognosis. A longevity of that would be much, much longer compared to the a 1 millimeter ferrule. Zero ferrule, no supracoronal, supragingival tooth structure. No, this is not going to survive for ever. This is a compromise only for a few days or few weeks. You can try. Anything more than 3 millimeter, probably you don't require a post for that condition. What do we do in case if we don't have a 2 millimeter of tooth? That's an important question. If there is a fracture, I'm going to share a few of my cases there. If there is a tooth fracture at a gingival level, per gingival level, what do? Equigingival level. In such conditions, probably we can think of CLP, crown lengthening procedures. Maybe your periodontists, or maybe if you have lasers, or maybe if you are good at it, that's a separate subject altogether. Crown lengthening or orthodontic extrusion can be an alternative therapies you can consider to gain that minimum 2 millimeter supragingival tooth structure. So minimal clinical crown, what is required for us is now more or less we are very clear. This review published in 2019 made it very, very clear that, okay, now the fiber posts are the in thing, and the conclusion was very clearly it says that minimal destruction of tooth, endodontically treated tooth, you don't require a crown probably. You can just manage it with just an intracoronal composite restorations. A moderately destructed tooth with less than 2 millimeter wall, probably using an adhesive inlays onlays could do, but severely destructed endodontically treated tooth with MOD cavities and the remaining two walls are at least a 2 millimeter supragingival, you need to consider the fiber post. This is a review article in 2019. This opens up a different understanding towards the post and code itself. That is what it is. So if I have to understand in a picturistically, this is what it is. So when we have all the walls intact, you don't require even a crown. Probably adhesive restoration would be fine. Here is moderate destruction. Yes, overlay or onlay should be fine. But when it comes to a severe destruction, where the remaining wall is thin and MOD cavities and there's a severe compromise on the height of the tooth, probably the fiber post core is the the ideal thing for such thing. Of course, endo crown can be considered depending on the patient's condition and the available the space between the upper occlusal platform to the lower gingival level. What is the space available based on that? Will the post-in court strengthen the tooth? No, definitely not. We don't have any scientific data which confirms that post-in court tooth is stronger than a simple restoration in otherwise perfectly perfect tooth. We don't have anything to claim that one. Routinely, can we use a post for all the teeth? There are many practitioners I have come across who strongly advocate the post for all the cases. No, our scientific data doesn't support that. You need to understand the root structure is not made for the post. The pulp space is surrounded by a dentin which is comparatively soft than the external dentin. If you understand that the dentin and tubules, they're wider and they get narrower. The inside dentin, it is generally coated with the pre-dentin, and during endodontic therapy, we take them out. And then whatever the dentin is there, compared to the dentin at DJ, then compared to the dentin at CDJ, this dentin is much soft and much different. And this is not made for a rigid body, it was made for the pulp. Now we are trying to take an advantage of that. Hence, when I claim that post-in court itself is a compromise compared to the otherwise intact tooth. But this compromise is a better compromise compared to the extraction. So that is how one should see the post-in court. If not post-in court, probably extraction. Hence, I don't mind doing the post-in court, but it can never compensate the perfect intact endodontically treated tooth. That is much stronger than a tooth which is treated with a post-in court. It may be very difficult to restore the tooth once the post-in court is done. Probably the retreatment becomes quite complex. You need to have certain equipment, you need to have certain magnification levels, you need to have certain skills in place skill sets in place to address that. It's not an easy thing. So hence, the routinely giving the post for any good intact tooth is not advisable at all. Limitation of the post is, as I said, it can be an anchorage to a core, but by default, post itself cannot take a load of the crown. Hence, it is not advisable to routinely think of post for any given conditions. What are the principles, basic guidelines, or basic idea behind this post-in court treatment? When we think of that, the principles gives you a rough or a very a broader idea about like what is that we are talking about. This is what it is. This is what we are trying to get at. Conservation of the tooth structure, that is conservation of the remaining supragingival and the remaining root structure. A retention form for the core and resistance form by means of a finish line and a ferrule effect. This is what gets compromised when you don't have the 2 millimeter supragingival crown structure for any given crown. So these are the things one need to understand when we talk about a retention form. The first thing is, yes, the post length. We need to understand how deep can we go. Then we need to understand what should be the width of the post. What size of the post can we select? Can we go for a thinnest possible, or can we think of the widest post to the given surface, given a root? What should be the surface texture? Should we go for a smooth post, or should we go for a serrated, threaded, or a roughened to surface? And what should be the luting agent? What should be the cement we should be using it to bond it to the surface? So these are all the things we are going to learn in few minutes. Post length is something we have nearly 16 guidelines about this. Everything works as long as you have a minimum of 3 to 5 millimeters of apical seal. This is what the first thing you need to keep in mind. You cannot barge into this space. You cannot violate this space. So you need to have at least a 5 millimeters of gutta percha intact at the apical third to make sure that you are endodontically, the tooth is not compromised. Imagine you have a perfect post, perfect core, perfect crown, everything is perfect, but then the tooth starts developing a lesion because you have a compromised apical seal. Then the tooth has to invariably either go for a retreatment where you have to retrieve all the post, or else probably you might have to think of extraction. What's used? What did we achieve? So hence, the 3 to 5 millimeters of apical seal is the most important when you are thinking of a post length. I'm going to talk about what are the concepts available now. Preservation of the 3 to 5 millimeter becomes the first and the primary important thing to be considered. Then we have other concepts like incisor cervical, whatever the tooth structure you are trying to replace. Okay, the same amount of the same length of the post can be inserted into the root surface, or maybe the post should be longer than the crown. How much? Maybe a third of its length. If the tooth is 10 millimeter, probably a 30%, something like around 13 millimeter post is advisable. These are all the different authors claiming different uh, suggestions for the post length. When it comes to clinical aspects, what makes it sensible? It would be this: a post should end halfway between the crestal bone and the root apex. This is very, very important. Probably you have the root all the way 22 millimeter, maybe exceptionally lengthy root, but you have only 4 millimeter of bone holding that root. You may put the post at the root, but if that root is not embedded in the crestal bone, this it is as good as not giving anything. So hence, when we are considering the root, we are always thinking that, okay, this root is strongly embedded within the crestal bone, and that bone plays a huge role in holding that root and making it strong, giving an anchorage to the core. So hence, your bone, crestal bone height has to be considered before considering the depth. There are concepts which says that post can be as long as lengthy as possible without disturbing the apical seal. Yes, of course you can do it, but sometimes considering the purpose, going anything more than 12, 13 millimeter for anteriors, 6, 7 millimeter for the posteriors wouldn't really make much sense. So the reasonable clinical guidelines to adapt it immediately. Probably you can consider 3/4 of the length of the root. That is like make sure that 1/3 of the length root is at least a 3 to 5 millimeter should be remaining to hold the apical seal. Then what are the other things? Average root length uh, when you have to compromise between the post depth and the apical seal. I don't mind compromise on the post depth, not on the apical seal. So my minimum size should be at least 3 millimeter, especially if I have done the thermoplastic vertical compaction, warm vertical compaction. In case of a lateral compaction or maybe a single cone perfect with a ceramic sealers, maybe 5 millimeter is the minimal thing I would be looking for. The post should extend at least a 4 millimeter apical to the crestal bone. That is another guideline you can consider. Once we have that much, and then the remaining 2 or 4 millimeter additionally would give you a 7, 8 millimeter of the bonded strength. Molar post, preferably keep it around 7 millimeter from the orifice. 6 to 7 millimeter should be more than sufficient, but make sure that 7 millimeter doesn't impede, that doesn't encroach the apical seal. So that is the rough guidelines you can keep in mind. So it is very simple that we say that the post can go up to the 2/3 of the length, provided the remaining length is around 3 to 5 millimeter. If this can be more than 3 millimeter, this can be 10, 12, whatever it is. Recommended length should be. This is an important slide for the people who have never done the post, especially when it comes to the molar or posterior post. Which root can we take it for an anchorage? Which root are we going to use it for the post? See this. This is again a review study which says that a molar post should not exceed 7 millimeter in length from the orifice, maximum 7 millimeter. Distal for the lower molars, palatal for the upper molars. Think like this. Preferably choose a root which is strong, wide, and straight. That is what it is. For a lower molars, your mesial is a slender root which always curves distally. Upper, your mesiobuccal, distobuccal are the slender roots, and they are not. They are your palatal is the stamp cusp. That is the one which takes the load. So hence, upper we prefer it on the palatal side. palatal root, which is straight. If at all, if there is a curvature that is happens at the apical curve, apical third, not somewhere in the cervical in the mid third, classically. So distal root is also, if you have a distobuccal and distolingual, preferably go for a distobuccal because that is the area where your upper crown comes in or contacts the lower tooth. So preferably choose the stem cusp, preferably choose the distal for the lower molars, upper palatal, about 6 to 7 millimeter would be the great thing. What should be the width of the post? Should I be using the strong, wider post or should I be using a thin, slender post? This controversy was there for a very, very long time, and whenever those who have done a sufficient post, they would have by now they would have understood that the slender post, if it is not sufficiently anchored by means of a bondage or by means of a resistance by threads and all those things, that generally becomes loose. So, while talking about this post diameter, we have three philosophies: conservationist, proportionist, and preservationist philosophies. Excuse me. Let's see one by one. What are these? Philosophies are not guidelines, these are all the ideas. Conservationist philosophy says that just take out the GP part and whatever the dentin is remaining, just smoothen the walls, remove the undercuts. That is what should be the width for the post. So don't try to cut too much of a dentin. Be in a very minimalistic approach. Just remove the GP points, smoothen the walls. The remaining space is for the post. That's the conservationist philosophy. The preservationist says doesn't matter. You just need to have a millimeter of dentin on either side. You can have any width of the post as long as you have a 1 millimeter of the dentin all around. That should be the concept for a preservationist. Proportionist says once you determine the depth, once you determine the length of the post, measure the width of the root. How do we measure? Measure it from one periodontal ligament to the other periodontal ligament. Divide that by 3, and that 1/3 of that length, that width can be your post space. When we say 1/3 of that can be your post space, imagine like when you have a 2 millimeter width, 2 divided by 3, probably you'll have 0.7 a millimeter. Maybe it's a very slender post. So these are all the philosophies. Sometimes we may work with the conservationist philosophies. Sometimes we may come to the depending on the root width and things like that. We may compromise on we may consider the preservationist or proportionist concepts. This is what roughly we can understand. But what is most preferred, advisable, and most conservative thing is a conservationist philosophy, where we have just removed the gutta after the obturation, just smoothen the walls, remove all the undercuts, and remaining space is used. But if that remaining space is less than, say, around 0.9 millimeter, it becomes very, very difficult for the fiber post to maintain its strength. So this is what we can consider: 0.6 to 0.7 millimeter for the mandibular incisors. That's thin, slender, very tiny roots. Probably this is what we can compromise on. But when it comes to the anteriors, upper anteriors, we can go up to 1.2 millimeter size post. Nowadays, size and the posts are available almost like ranging from 0.7 to 1.5 millimeter, and the specific drills are mostly provided accordingly. You just have to use a corresponding color-coded drill, and you will get the thing. How to remove the GP and how to make a post case, we'll discuss a bit later. What is most important, the length or the width? I would say, yes, it is the length which matters. You cannot have a 2 millimeter post. You cannot have a 3 millimeter post. At least you need to have 5 to 6 millimeter for the posteriors, at least 9 to 11 millimeter in the anteriors. Anything less than that would compromise on the retention. Width is okay. As I said, three philosophies suggest us like the conservationist is the best thing because we can have a minimal width, but that minimal width also can be depending on the tooth. For a posteriors, at least around a millimeter would be a better idea. So when it comes to length and width, length takes a better length gives a better anchorage. Surface texture. Should we use a smooth post? Should we use a rough surface or a serrated or threaded post? Now, this question doesn't arise because nowadays what we have the fiber post or the glass post and the ceramic post and all those things. Since we are going to bond them, the surface roughness doesn't really play a major role. But having said that, most of the fiber posts now available with either brood or you have a roughened surface and you have serrations and so many things are available. But as long as you're going for a bonded restoration, bonded post uh, with a fiber or a glass or a ceramic, it doesn't really matter. What is the ideal shape? Should we go for a tapered post? Should we go for a parallel wall? It is said that if you, we always, when we draw the picture of the root, we draw it like a tapered roots. But if you see an any extracted tooth, you can make out that the tooth is almost parallel to certain level and then it tapers. The root is always parallel and then it tapers. That is the configuration we should be looking for. From that perspective, we always say the parallel posts are most retentive compared to the threaded post. The biggest problem with compared to the tapered post. Tapered posts, the moment they list large, and if there is any retention issues, then they will act like a wedge and split the root. Parallel posts most retentive, and maybe at the apical third they can have a little bit of a taper, but more or less the surface should be tapered like this. These were all the metal posts, and we always preferred a parallel post. Nowadays, metal is not anything, so I don't speak. It doesn't really matter what we understand here. A mild tapering, very less thin, or something like this, made from the fiber post would be an ideal uh, shape. So ideally, this is what we can say. We need to have at least 3 to 5 millimeters of gut aperture at the apical third, not wider than the 1/3 of the root diameter. Anything less is better. Serrated or a rough surface. Most of the fiber posts are like you have a rough surface and parallel shape. This is what is the ideal post we would be looking for. How to plan a post and core treatment? If patient walked in and this is a theoretical part, we understood. Now how do we go about it? Uh, if I have to take to the whole process, this is how we evaluate. First, evaluate the tooth endodontically, how stable it is. There should be a good apical seal and no tenderness, no exudate, no fistula, no lesion. Probably the tooth is absolutely asymptomatic. This is when we consider. Most of the time, clinically, what happens is, let's say you have a patient with a chronic lesion and a fractured tooth. Now, should we wait for the lesion to completely heal and then go for the post? No, not really like that. If you follow the principles of endodontics and if you follow the perfect irrigation protocol and if you achieve a minimal viable width preparation for a given canal, of course, you can go ahead with the post irrespective of the clinical, irrespective of the radiographical lesion. It will more or less heal. Our success rate is nearly around 93 to 97% as in today, so we can trust that one. Then coming to the other aspect, how do we select the tooth for a post? We need to consider the amount of remaining tooth structure. That is the most critical point here. Anatomic position of the tooth. Is the tooth in the proper position or is it tilted? Functional load on the tooth. Is a opposing side. Is it a full complement of a tooth, or the patient is wearing a denture, or is there a missing tooth? Now, this gives you a tremendous confidence on like what is the type of post you should be using it for that given condition. Of course, the aesthetic requirements. Patient wants to go for a metal-free lithium disilicate crowns. You may not be able to think of a metal post or a carbon post. You cannot give a darker post inside that. You need to have aesthetic considerations as well. Clinical procedure, probably this is how we theoretically understand. Towards the end, probably I can share a video with you all. First thing is, it is done in 3 stages. First, we need to create a post space. For that, we need to remove the gut aperture points. Enlargement of the canal to reach the specific width, a minimal width, proportionist, or conservationist, or preservationist philosophies. Preparation of the coronal structure. You need to give the finish lines, you need to have a ferrule minimum 2 millimeter, and you need to give the bevels depending on the core build of material, whatever we are using. So how do we remove the gutta percha? We have several methods. We can use a thermoplastic pluggers. We can use a Gates Glidden drills. I'm sure that you are all aware of the sizes of this. The Gates Gliddens are available from number 1 to number 6, ranging from point 0.5, zero point 0.7, zero point 0.9, 1.1, 1.3, 1.5 millimeter. But when it comes to piezo reamers, the number changes. The first drill is going to be zero point 0.7 millimeter, and the last drill is going to be 1.7 millimeter. So there is a slight difference you need to understand. The number of rings are the indication of what is the size we are using it. And system depluggers, as I said, ideally we cannot use GP solvents. Keep in mind, no solvents while preparing the pore space, because we don't have any good control on these liquids. Probably they would go beyond certain level and compromise on the apical seal. For us, that is very, very important. So preferably, we have complete control with either hot instruments or with a Gates Glidden. My personal favorite is always a Gates Glidden. But nowadays, the good thing is, whatever the latest post you're all using it, they all come with the specific drills. That means that you just need to buy a kit and they'll give you specific drills corresponding posts. You just need to go with the sequence and place them. Things have become really, really simple now. So once you have your length measured, once you determine your the width of the post, you just need to use a sequential use of sequentially. You are going to use the a post, Gates Glidden drills, and then achieve the maximum possible size for that given canal. Here is a clinical tip I would like to share. Uh, can we make a post space immediately after obturation? It all depends on type of obturation. If you're doing a warm vertical compaction, yes, you can think of immediate post-space preparation, especially with the resin sealers and the resin eluting agent. If you're thinking of lateral compaction with the eugenol based sealers and the other things, probably it's better to wait for a few days, at least 2-3 days before you drill the thing. And then if the tooth is obturated many years back, your GP has gone from a beta to alpha phase, and probably it would have become really hard. The phase transmission would have made the gutta percha very hard. And if you land up using a number 1 GG drill, most of the time you will land up breaking them. That is what I have seen in the colleges. That is what I have seen with many of my PG students. That when they use a smaller size GG drills in old obturations, the first one breaks. So to avoid that one, preferably start number 2 GG drills, strong enough. It has a sufficient material bulk to cut the thing. And second thing, should we need to use any coolant? No, absolutely not. Don't use any coolant with the GG drills, because the frictional heat is the one which is cutting the dent, which is cutting the gutta percha point. If you keep on cooling it, probably it will not be able to create that minimal temperature required to melt that, to soften that GP. So you can cut with a physical rotary movements, but not really efficiently. So I don't prefer using it, but it doesn't mean that when we can use the GG drills at whatever the speeds. I have some recommendations. I will share that very soon. Guidelines for the post-space preparation. This is how it goes. Before removing the gutta percha, make sure that apically 5 millimeters of GP is available. Use number 2 or 3 Gates Glidden. Drill till the mark, whatever the things you have achieved. I have videos. I can share it at the end of the presentation today. So measure the length, adjust rubber stopper, make sure that your drill is rotating in a clockwise, and go to the full level. And then sequentially change the drills till you reach the desired width, whatever has been determined for the given tooth. And the canal, yes, should we use a piezo, or are we fine with only the GG drills? As I said, most of the present day posts are available with their own drill. This is not a big question now. When do we use a piezo reamers? If you want to have a perfect parallel walls, yes, the piezo reamers would always help you here. GG is the first drill that goes into the removal of GP, and then after Gates Glidden, to smoothen the walls, your piezo reamers can be utilized for that purpose. Here is the thing: when you use GG drill or a piezo with a very high speed, then this is what is going to happen. Suppose if you have anesthetized the patient, you may make a post space and all those things, but the heat generated is so much. There is a one study I can vaguely remember, the temperature changes, anything around more than 10 degrees may cause some kind of a resorptive changes or inflammatory changes at the periodontal ligament level. So hence, it is not advisable to use any drill more than 1000 RPM. And I have also noticed the one thing with many practitioners. This one set of GG drills, they've been using it for over the years. Think like this: the GG drills are not technically they are supposed to be from the carbon steel material, but nowadays, whatever is available with our neighboring countries, they are simple stainless steel. That the cutting ability very rapidly comes down, and it starts generating a lot of heat. So the G drills frequently need to be changed to make sure that its efficiency is maintained. If cutting efficiency is good, you can work with the lower speeds. If it is not cutting, then probably we would either apply pressure or increase the speed. Both of them would cause a lot of heat damage to the surrounding tissues. This is something critically important during the post-space preparation. Once we have the shape and the size, then it comes to the bonding process. As I said, I have a video. I'll show you all later. If you're adamant on using a threaded post, if you think that you're a strong, if you believe in this concept and the mechanical locking, there's a one tip I would like to share. I have seen many practitioners, they leave the post head somewhere in between and try to build a composite over the post head. Always make sure that your threaded post head comes to all the way to the level what you consider as ideal length of the crown prepared tooth. That is what it should come, and that is where the direct transmission of the load happens on this. Try not to put the post head somewhere here and try not to build a core over that. First of all, the bond between the metal and the composite or all the material itself is compromised. On top of that, try not to put a metal and then the composite and then again a crown over that. Probably you will not be, there will be too many materials to share that load with the different physical properties. May not be my recommendation. Though we try to drill as center as possible, depending on the tooth structure, you cannot deviate, you cannot make your own post space. It is always in the root surface. So always make sure that you may see something like this, thinking that you have over drilled on the one side. No, that's not your fault. It is the root configuration. How do we cement? The luting agents, at one point, luting GCs were the only methods. Before that, there was only a phosphates or silicates. Now we have a various wonderful dual cure resins, and they give a great bonding with a very minimal clinical procedures. So we have a Maxim, we have a Paracord, we have resin modified GACs, we have a luting GACs, various things can be used. But for a fiber post, I would always prefer a resin, a dual cure, luting agents. Should we apply the luting agent over the post, or should we inject it into the post space, or should we inject and then apply onto the thing? Now with the available resin cement cartridges and with the delivery nozzle, we should be able to inject perfectly into the post space and then place the post inside. This also, I have a small video I will show you. This is what I said. Now there are various brands available. There are various delivery tips, which is perfectly fits into the whole depth of your whatever the things you have prepared, at least a millimeter wide. Inject it, slowly withdraw, let the whole thing fill, and then place the post inside. That is the most advisable thing. A risk versus benefit with a metal and non-metallic post. As I said earlier, metal posts always lead to this wedging action, and the metal is rigid than the root, and we always land up seeing this kind of fractures. 10% of the failures are always attributed to the root fractures. Say that whenever there is a flexural force, that always transmitted the forces onto the post and then to the root. Right, either vertical or oblique cracks, very commonly seen with the rigid posts. Cast posts or custom-made posts are, to be honest, it's not my personal favorite. I do a very less cast posts, but still, being a part of this whole topic, I need to discuss about this. The difference between the prefabricated post and the cast post, now they overlap so much we hardly see any difference. Even that has been confirmed with our various studies. So custom made posts are, we can do it in two ways, either direct method or an indirect method. Uh, when we think of custom made post, like any other post, you need to have a minimum 2 millimeter of tooth structure being intact, and you need to give a finish over the a natural tooth, not on the restorative material, not the natural tooth. And as I said, if you don't have the 2 millimeter, probably you're transmitting all the forces to the post, and that would eventually lead to the root fracture. This is a clear example of how the loads, are acting on the any given tooth. Nearly on the buccal side, uh, roughly around 47 megapascals, and on the lingual side. And imagine that if you don't have a natural tooth here, your restoration will not be able to take that load. That is very important to have the 2 millimeter of the tooth structure. If not anything, at least 3 watts, buccal, lingual, or mesial, or distal. That makes a lot of sense. So here is a clinical guideline for you. If you have minimum 2 millimeter, be it a cast post or a fiber post, yes, this would have a better prognosis compared to no tooth structure at all. They would not survive compared to these things. They may survive for a while, but you know that if the patient is ready and you are doing it as a transient treatment therapy, okay, this is acceptable, not as a permanent solution. This can be as close to as a natural intact tooth, not definitely. So ferrule, if you have to understand, it is technically 2 millimeter of metal band around the finish line, what you're going to give, which is going to hold the tooth structure intact and prevents that a lateral forces being acting on the post as such. Or else the post is the one which is trying to deflect according to the forces applied on this. So that's the way we understand the ferrule. So how do we do the tooth preparation? Make sure that here is a clinical tip I would like to share. Just after endodontic therapy, there is a common trend that we always tend to do the coat buildup first and then the tooth preparation for a prosthodontic, for the prosthesis. Just change a little bit. Always just follow this simple rule, simple technique. You will always appreciate the amount of tooth or the kind of results what you see. Remove all the temporary filling material after obturation in the coronal area. Remove the GP till the orifice level. And then do a gross preparation of your prosthetic or tooth preparation, what is needed for your prosthesis. That is when you actually will know how much of tooth structure is available for you. Otherwise, there's a way. If I restore this tooth, probably with a composite or something, I wouldn't really understand how much of actual tooth is available with me. So from that perspective, it is always better to do a rough or a gross preparation for a prosthesis and then see the available tooth, and then you can definitely take a call accordingly, whatever is required. So direct procedure is more or less like, we make a post inside the patient mouth on the tooth prepared with itself, or else we use various materials for this, a pattern resin or the inlay wax or various materials. There are certain composites available for this one. You can inject and you can make a pattern in the patient mouth. I don't really suggest the direct pattern procedures for the simple reason that if you're doing the same procedures again and again for many days, many times, your fluency, your hand-eye coordination would be much better. But if you're doing maybe not so frequently, rarely if you're doing, your hands are not so tuned for this procedure, I would suggest make a post piece, take an impression of that. Excuse me. I would suggest inject make a post piece, support it with either with a pin jet or with a loosely fitting toothpick, and then take an impression. Send it to the lab. The lab is in a better position to make a post because they deal with this wax or the materials and the patterns, and even if it fails, they'll have something else. If your direct pattern fails, you will have to redo it again and again. And here is a patient, which needs to make a multiple visit. Think of a corona and making a multiple visits. So it need not be a fiber tip. You can use a toothpick as well, or you can use a pin jet. A pattern resin or wax is applied onto that. Take impression of that. This is a direct pattern method. Indirect pattern, technically taking the impression of the pore space. Let's see what is the failure rate of the posts now. So commonly seen pattern is a loosening or a dislodged post. Why does it happen? This is most common in case of a fiber post or resin post because mostly a contaminated surface may not be able to bond with the luting cements. That would be the classic thing. A fracture of the post and core could be improper size, improper depth, maybe a metal post. We see a lot of things. Fracture of root, highly seen in the rigid metal post conditions. Root perforation, it's a iatrogenic problem, wrongly drilled tooth, and post and core failure because of a secondary caries, because of apical abscess, a failed endodontic therapies, and all this. These are the things. But what we see out of 100 failures, we see loosening of the post. Here, either if you're doing a metallic post or a rigid metal post, probably the fit or the casting defects may be causing this one. In case of a fiber post, probably the resin cement may be not bonded either to the tooth structure or either to the your resin post itself. Apical abscess, yes, if that 3 to 5 millimeter of apical seal is not maintained, invariably you're going to have this problem. Tooth survived, post is doing well, everything is fine, but the patient landed up in a endodontic problem again. Caries, it all comes down to how well you have bonded, how well the finish lines are, the foot impaction, and then the various, of course, the patient factor as well. So in a nutshell, this is what we can understand. If you have at least a 3 to 5 millimeter of gutta percha, they will hold the apical seal much better, and wider or lengthier apical seal is far better compared to the compromised 2 millimeter or less than 3 millimeter gutta percha. Some of the clinical compromise cases, I would like to share just to give you an idea, like sometimes how the small things. Here is a fractured tooth. Patient had various other things he wanted to make it right. Here we cannot think of perfect smile design. This is we are still in the process. A little bit of crown lengthening, and when we try to align the tooth, we landed up compromising on the coronal tooth structure. Color changing post, I will discuss that during the video. So the post should be along the root, not to the crown, whatever you want. So it is a basic rule that your post should be aligned parallel to the long axis of the tooth. Parallel to the long axis of the tooth. You may deviate the preparation according to the aesthetic requirement, but make sure the post is along the long axis of the root. So here it is, but when you prepare the tooth, probably it would look like this. We have just temporized it as it was before. Still a temporaries. Still temporaries. Okay, here is a condition where endodontically it was treated. When we did a gross preparation, we could make out the palatal wall is completely lost. There's hardly anything. Mesial wall is intact, buccal wall is okay. Now I have nearly 2 walls completely being compromised and a very little denting on the proximal side. we have prepped the post space. Now I have two canals. Now straight, wide, and knowing like upper second premolar, you can make out it's a dumbbell shaped root, and probably the palatal should be fine, but since they're joined, so I decided to place a two posts there. Inject your resin cement, place them, cure it, prep them. The color changing pose, the benefit is like it's easy to identify during the retreatment, and then prep the tooth. Take an impression, send it to the lab. Meanwhile, temporize it. Here is another condition where there were all the walls, but they were all less than a millimeter. It may not be able to survive, and there is a defect there. So, though I have a sufficient length, but the thickness of the walls were highly compromised. Hence, I had to go for a post. Again, take the impression, send it to the lab. This is one of my decade-old case where I'm sorry about the size of the picture. These are the analog films. I had to take it. You see, there was a root separation because of secondary caries. So we wanted to do the hemisection. This is where we violated the basic principle a little bit, just to gain a little anchorage. So after the hemisection, we removed the distal root. The mesial root was intact. And cleaned up all the things, waited for 15 days. And then we just went 4 millimeter into the both the roots. Little caries restored. Tooth. Now you can make out this tooth looks more or less like a premolar preparation, but this is a mesial root of the first molar. If I had extract this tooth, if the patient had to go, I had to make 3 units of crowns. Now probably I will just make 2 units. That's it. That's a temporary. Upper canine, RCT was done long back. Patient didn't go for a crown. There's a secondary caries, weakened the root. There's another premolar. The pictures are just interchanged. Our first premolar, a straight roots, almost same size. Some of the companies follow this one. They give you a thin metal wire at the center of the post, so that when you take an X-ray, you will get an idea how deep the post has gone. This was the tooth I was talking about. Post space. Make sure it is like you have removed all the caries portion. Inject the resin cement. Patient wanted to wait for a while, so we just gave an aesthetic replacement. There's no problem. We just gave a composite restoration on this because of the patient's financial issues. Here is a compromised tooth where the patient comes in the first patient in the morning, root canal treated tooth, fractured, upper canine, 1, 3, and now patient was heading to the office, and now we need to do something about it. We know that there is no supragingival tooth structure at all. This is what the condition was. Patient was convinced that okay, she needs to think of either bridge or an implant for this. For a time being, now we thought of just cauterizing the tooth structure, the gingiva, a little bit to gain the minimal surface, at least a millimeter. Tissue was charred a little bit for space preparation. This is a highly compromised condition, but it's a transient treatment. It cannot be a permanent treatment. There is no supragingival tooth structure at all. We are just building it over the post. You can make out that the post is the one which is holding this temporary crowns. This is on for a few days. Luckily, we had done this a little crown lengthening to, which is, she doesn't have a gingival zenith of a perfect this thing, so it is okay. That is what it is. That was a mistake. This was a case, very unconventional way we had done it. Again, there's hardly any tooth structure. This available tooth was, though it was like a millimeter and a half, it was like hardly less than a half a millimeter in width. Again, a transient treatment plan. We sealed the remaining space, the whole length was 15 millimeter. This patient had this fractured tooth for almost like 5-6 years, and she never bothered about replacement of that tooth. And then suddenly she wanted to replace that. And surprisingly, there was no lesion, though it was kept open for many years. So we sealed it with the MTA there. And then a post, you can make out there is no ferrule here. In fact, we gave a crown because patient wanted to wait at least for a few months for personal reasons. So this is what, in a nutshell, I can say. Post-and-core is a last chance we are giving it to the tooth. Don't be under the impression that we are going to strengthen the root in any which ways. This is a better compromise compared to the extraction. Keep your objectives very clear. You should have a clear concept that what you are doing and how you are doing it. You know your limitations, know the procedural limitations. Preferably avoid a rigid post. Your posters, if you give a strong metallic post, your root is a weaker structure. So preferably either match the physical properties of the dentin. That would be the ideal condition. What to look in future? We have a CAT cam, we have a digital scanning, scanners, and all those things. I'm quite optimistic from the perspective that we will have a resin or a fiber post, custom-made fiber post, which is an ideal condition. Scan and get the fiber post according to the root configuration. That will be the ideal thing to look forward. While doing the procedures, we may do certain mistakes. Unintentional is okay, acceptable. We all do that mistake. But when it comes to intentionally knowing certain things and not following it would be the disaster. So it's okay. Now, while learning, that might happen. I would sincerely thank all the association members and Dr. Anand Mata and Dr. Saurav, Dr. Adit, for giving me this opportunity to share a little bit of whatever I knew about this post-and-core topic. And thank you. I'm open for the questions if you have any.
Thanks a lot,
Yes,
sir. It
sir.
was an amazing, wonderful session. I guess Dr. Saurabh has a few questions. Dr. Saurabh.
Yes, sir. Thank you, sir, for a very in-depth and comprehensive lecture regarding post and course. We had many doubts, but as we went through the lecture, most of the doubts got answered in this lecture itself. So, sir, one doubt I have got two, three questions is: do we treat the fiberglass post with any etchant bonding sealant before we do the post and core with dual cure material? So, what is
That's a
your take on that,
very
sir?
good thing. Can I share a video at this point, Saurabh?
Yes,
Yes,
sir.
sir,
Please.
definitely. I'll just get the screen. Yes, sir. The screen is on, sir.
Here it is like in a condition where I intentionally fractured a tooth. This is one of the demonstration I was given. Tooth was intentionally fractured. X-ray was taken, obturated, measured the length, and it is almost like around 17 millimeter. So you just need to make that 5 millimeter dent in the apical seal should be intact. So once you mark that 5 millimeter, I'm just this you can do it with the radiographs or RVG and those methods. You'll have a working length. You can use that one also. So once we keep that 5 millimeter intact, I still have 12 millimeter. Now the question is, should I really need to prepare the 12 millimeter? No, it is not required. This is a minimal depth expected. Maybe 10 millimeter is also good. 12 is a maximum. I can do that. I use a GG drills and measure the length. Always make sure that, if you want to drill 10 millimeter, go at least at the 10 and after 12 because the tip is non-cutting and your post will not go all the way to the tip. So hence, if you want to drill 10 millimeter, keep the length for 11 millimeter. So adjust the length. Now I'm planning for a 9 millimeter. Now I can drill the post space right at this point because the tooth looks pretty okay and I can build it up and then do the things. Or probably I can prep the tooth and then go for the drill. That is the best way. So gross a tooth preparation. Remove all the weakened, unsupported, and here unfortunately the tooth had a fracture. And then you know your measurements, drill them. Start with the number 2 GG drill. Here the most common mistake that happens is as the GP extrudes, it start pushing the rubber stopper up. And if you are not focusing on this, you keep drilling and the rubber stopper keeps going up and then you land up, impeding on the apical seal. So one has to be careful about that. Start with a sequential widening of the preparation till you see a wide dentinal shaving because we are going with a conservationist approach. Initially, you see the sealer, and then you can make out still it is a GP point which is coming out, and then you start seeing the a wide dentinal thing. If you're planning to do a molar, the same procedure, apical 5 millimeter should be intact. Measure the remaining length. So you more or less, from the orifice, you'll end up going around 7 millimeter in any which ways. So here it is like roughly around 12 millimeter. Probably I'll be preparing around 10 millimeter here. Then same step, take the tooth. Now here I had uh, an hourglass shaped canal. When you find such a distal root, probably you can put 2 posts in that space. Always make sure that your other canals are also orifices prepared. Now coming back to our central incisor, uh, cleanse the tooth, remove all the dentinal shavings and the sealer and all the things. You can think of a EDTA as well if you have used any calcium hydroxide based sealers. You can use ultrasonic tips, you can activate them. Now there are many fiber posts available, as I said, the smooth surface or a serrated or a grooved surface, various types of posts are available. The color coded you have from 1 millimeter to 1.8 millimeter. Here the selection should be done in such a way that the post should not be snugly fitting. It should be little loose. It should be little loose in any given preparation. When it comes to central incisor, I would select the one which is here. It is like the preparation was around 10 millimeter. So it goes all the way down. Should be a little loose. There should be a space for the cement to flow. These are the color changing posts. The beauty of this is the moment it reaches the body temperature, it becomes a tooth color or a dentin color. And if you put a little water, it goes back to its pink or blue color. That is important for the retrieval. You can use a various luting resins available. Paracore is one of the, Maxim is another one. There are some conditioners and there are some initiators. Here is the thing, answer for your question. In case if you have touched the post and if the surface is contaminated, or in case if there's any issues with the thing, apply the silane agent. No need to cure and no need to do anything. You just apply the silane agent, make sure that you don't touch this surface again. And blow the air. If you are going for a aesthetic preparation, preferably choose the luting cement accordingly, either transparent or a dentin shape. As I said, now the delivery tips they can reach the full depth. Inject dual cure resin. Now this is placed. Cure it. This paracord material can be used for even a pore buildup as well. Regular composite being used. Build up the core part, whatever you wanted it. Do we need to apply the bonding agent and all those things? No, previously whatever you have treated with the conditioners and the bonding agent, that will take care of that. So consider the height and all those things. What is that you're looking for? Build them. Cure it. And again, you need to prep the tooth. Here, let me use a Maxim. Self-cure, self-adhesive by curd. I'm not supposed to touch that surface. That's a mistake. Maxim is a color changing resin. Once you cure it, it becomes a dentin shape. That means the polymerization is complete. Then build up the core part according to the opposing arch and the neighboring tooth and the clearance and the type of a finish line, whatever you want to give. The configuration factor is not an issue because you don't have, except the one wall, you don't have much of a dent in all around. So you can think of building the multiple walls simultaneously. Whatever the excess post is there, you can use the same burr to prepare it. Prep the tooth again. This goes with your prosthodontic tooth preparation principle. Make sure that you are around it edges. I'm trying to show one anterior, one posterior, so that you get a fair idea. So on the X-ray, you can make out this two white lines are your resin cement. If they're very, very thin, or if you don't see these white lines at all, that means that, okay, that there is not sufficient loading that is happening. You need to have at least 500 microns of this thickness. Comes to the posterior. The same two lines. Of course, it is a compromised obturation. I had just taken a tooth which was available. So that is very important for us. Yep. Saurabh?
Yes, sir. Thank you, sir.
Did I answer that?
Yes, I guess we have. You have answered that very well. So, can I take a few more
Yes, sir.
questions?
Yes, yes.
Yes, Dr. Anand.
Yeah. So, one second. There is a question from Dr. Viral Patel. If mesial half of a lower molar is lost, then also we use a post in the distal canal. Would it help, or what should we do?
Sorry, I didn't get that question.
So, there is a question from Dr. Viral Patel. If the mesial
Okay.
half of a lower molar is lost, then also we should use the post in the distal canal, or should we use
Yes,
it in
yes.
the mesial canal?
The angulation, I understand the question. Though the mesial half is missing, you still need to put the post in the distal itself because the angle of that tooth is, the root is such that it extends towards the mesial only.
Yes, it will come towards the center.
Exactly. And the same thing holds for your upper molar also. Though your buccal side is missing, you still need to put the post in the palatal.
Thank
You,
you,
you can
sir.
have,
I have. Yes, sir.
yeah.
It is pretty clear. Yeah. Another question from Dr. Priyanka Pitle. Selection criteria for post and core and C-shaped canals.
Uh, uh, that's a highly controversial thing. You know, the C-shaped canal can be just a ribbon-shaped or very thin isthmus, or it may be a major space. But however, what happens is like even in the C-shaped canal, the root need not be exactly C-shaped at the apical area. So I can vaguely remember one of the white paper presentations. We preferably go with the not the whole preparation. Use a resin sealer and then prep the tooth either distally if you are talking about a lower molar and then the fiber post. If you have a sufficient space, if you see that the C configuration is like sufficiently wide enough, then use your ultrasonic tips, digital scanning, maybe a custom-made post. This is a more or less a very hypothetical question. Clinically, if the C-shaped root is there and a crown is fractured, in case of a lower, I would still prefer going that at the distal side.
Great. Thanks a lot, sir. Another question from Dr. Arbia Anjum. Methods of retrieving fiber post.
Okay. I didn't hear that question.
Methods for retrieving fiber post, sir.
Retrieving the fiber post is the most challenging thing. You need to have a ultrasonic tips. There is a Dentsply has this X tip, which is you will actually use for calcified canal orifice opening, and you need to do it under microscope. And color changing post comes as a big advantage there, especially if you put a one drop of any room temperature water, the color changes there. Let's say the post has been the tooth colored or a composite, and it's a very difficult to differentiate between the core buildup material and the fiber post. Then it becomes very challenging. Either you need to go with a guided preparation. That means that need to get a CBCT. You need to make a guide, a surgical stent sort of a guide, and then drill through that and take an X-ray every 2 millimeter drill with every millimeter depth.
Okay. Great. I guess, Saurabh, I am done. If you have any questions, please.
Yes, sir. There's just one
Hello.
or two more questions. So there's one question. Hello. Yes, sir. Just one or two more questions, sir. There's a question by Dr. Anand Jain, who says, "Do you always fill up canal separately with core buildup and then use packable composite for the core buildup, sir, in the root and the
It
crown
was
space?"
breaking. I could not hear the question.
Sir, do we always fill canal separately and core buildup separately with packable composite?
That's what I would prefer, because most of the dual cure core buildup materials, what they have is, they're all in the a flowable form, and the filler component is always a questionable. So I would prefer post with the dual cure resin, and then the core with the any posterior composite or highly viscous packable material. I would strongly advise that.
Yes, sir. Okay, sir. I think there's one last question we'll take, sir, about the dead space between the post and the GP, sir.
I was expecting this question. Should we have that space? If it's a passive post, no, not needed. It can be there. But my question is, do we have a control on that? Are we so specifically able to control that? If there is a 0.5 millimeter space up to a millimeter, I don't think that can pose a problem. But that used to be a major issue when it comes to threaded post. What we used to happen, we used to thread them, and that applies a pressure on the remaining GP, and there is a possibility of like extrusion and things like that. At one point, I remember, my early days of PGs, where we used to say minimum 1 millimeter of space is needed for that. But now with the passive post, it's not really important. So 0.5 millimeter, 1 millimeter, the space, no space, and all those things, it doesn't really make a difference.
Great.
Right, sir. Thank you, sir. Thank you very much, sir, for your time. Dr. Anand, if you have any queries or...
I guess we are done. Thanks a lot, Dr. Raghu, sir. It was
Yes, sir.
amazing. It was a beautiful
It's
session.
my pleasure.
It was. I hope I am meeting you when I come to Bangalore. It was
Sure,
amazing.
and we'll definitely meet.
Listening to you, I am
I hope,
more eager to meet you. So it was wonderful,
Great.
sir. Thanks a lot. Beautiful session. Just a small announcement. The questionnaire for today's session would be posted by tomorrow morning. So please make sure you go through it and please answer the questionnaire. And we'll see you all again after 3 days for a session with Dr. Shibu Sridhar on restorodontics. Thanks a lot. Bye-bye. Good night. Take care.
Thank you. Good night to you all.
Thank you, sir. Thank you.
Thank you.
Good night, sir. Take care.